Now, what makes clinical research difficult to read and understand is not really the fact that it is difficult per se, but because there's a lot of terminology confusion. So these are the main parts of a research paper. The first part is the research question, statement or hypothesis. The second and third parts are very important. That is, why the study needs to be done and how is the study going to be used. The fourth part is the biggest part, which is with regard to the internal validity of the study. The fifth part is with regard to sample size or study size. And the sixth part just clarifies on this concept of external validity. Now, when we look at a research paper, you'll find that it's very wordy, but a lot of it is not necessary for us to judge the quality of the paper, in the sense that these are things that are not original to the study. So unless you are not familiar with the topic at all, you can more or less skip the literature review section or just read it through very superficially. Likewise, the discussion part. But the way the literature review and the discussion is written gives us a sort of clue as to whether the researcher has been trained to do research or not. Okay, the first part is the research question, statement or hypothesis. Some questions can be stated in all three forms. For some type of research questions, you have to pick one form or the other, right? So the same thing, let's state it in all three ways. Now, for a question, we will ask something like, what is the average height of primary 6 student in Seafield Primary School? If we want to state this as a statement, we will just say that we want to record the average height of primary 6 students in Seafield Primary School. If we want to state this as a hypothesis, then we will state that the average height of primary 6 students in Seafield Primary School is 4 feet 6 inches, and the study will tell us whether our hypothesis is true or false, right? Now, sometimes the reason why the study needs to be done and how the study is going to be used is important, because that allows us to decide how stringent the internal validity needs to be. For example, if we are going to do a study weighing newborns, right? Now, if we are going to do that study to calculate the IV regime, then we need to use a high quality calibrated hospital scale. However, if we just want to sew baby clothes, then we don't need to spend the money to buy that hospital scale. We can use a bathroom scale, right? So, how the study is going to be used and why the study needs to be done also plays a role in how stringent the study needs to be, or the study ought to be. A note about the internal versus the external validity. The internal validity is simply how well does the study answer the research question posed. Now, the person posing the question is the researcher, and how well does he answer the question, and how well does he document the bias. Now, internal validity is the responsibility of the researcher. External validity is how applicable is this study to those not in the study. How applicable is it to the population at large? Now, this is not the responsibility of the researcher. That is the responsibility of the reader. Okay, now we come to internal validity. Now, there's a lot of confusion with regard to study type, study design, and study sampling, right? So I think the easiest way is to break it up into 3 different topics. So for every paper you read, you can record this separately. This is to prevent confusion. Now, the common kind of studies in medicine are the epidemiological studies. Basically, these are just observational studies where you just follow through with the patient. Now, the common kind of epidemiological studies are incidence studies, prevalence studies, just recording demographics, and the association studies, whereby A is associated with B, not necessarily A caused B. Then you also have the clinical epidemiological studies where you record patients' diagnosis, their management, their complications, their outcome. So this basically gives you an overall general picture of the condition. Then you have got the battery of test accuracy studies, and pathologists must be familiar with this. You have got the diagnostic test accuracy. That's basically how well does this test pick out a diagnosis. Then you have got the prognostic test accuracy, where it's basically how well does this test prognosticate, and the predictive test accuracy, whereby it's usually how well does this test pick up those patients who will benefit or not benefit from a particular drug. Then you come to the exposure outcome type of studies, where you are trying to say A caused B, and these are the kind of studies that physicians usually do, and physicians need to understand, right? So basically what you're trying to determine is if the effect of exposure A on outcome B. So A can be something beneficial like a drug, something unknown status like smoking, of course now we know it's not, or something frankly dangerous like a poison, and the outcome can be the effect of drug A on hypertension, smoking, whether smoking causes lung cancer, and whether poison can cause death. So these are the 3 main kinds of study types in medicine. There are others, but we will focus on the main types first. Now, once you decide on the type of question this is going to be, is it an epidemiological, is it a test accuracy, or is it an exposure outcome study, then for each type of study there are many different study designs, each with its own pro and con, and there's also a certain kind of hierarchy. Some study designs are better than other study designs when it comes to answering exposure question because of the issue of temporality, right? You must be able to say exposure A came before outcome B. Only then will your exposure outcome study be useful. So let's just look at study design for exposure outcomes. Now first is the usual prospective study. You give drug A in 2019 and record the outcome in 2020. Then you have got a number of retrospective studies where from past records you note who has and hasn't been given drug A, and then again from past records you see who has and doesn't have outcome B. Or you can look at past records in 2000 to determine who was given or not given drug A, and now you can go and collect the data on whether they have outcome B or not. The other type of retrospective study is sometimes also known as ambidirectional, is where through past records you find out who has been given or not given drug A. Then in the future, in 2020, you can determine who has outcome B and who doesn't have outcome B. So the commonality between all these studies is you always start with the exposure and lead on to the outcome. Now there's another kind of study known as the cross-sectional study, where you ask the patient both whether they had the exposure and outcome, but you ask them at one time point. Now this can be very effective if the exposure is something memorable, or the exposure is something fairly recent. But it may not be so effective if the exposure was a long time ago or it's not a memorable type of exposure. So cross-sectional studies can be used to determine exposure outcome, but often you just end up recording an association because the exposure may be too far in the past or not a memorable one. Then you have got the case control study, whereby you start off with those who have had outcome B and those who haven't had outcome B, and you look back at old records to see who was exposed to exposure A and who was not exposed. So as you can see, this one is going forward, this one is in one time point, and this one is going backward. But for all, you end up with a record of exposure A or not and outcome B or not. Now, there is a huge source of confusion here, as I mentioned, where people confuse study type with study design and sampling methods. Now, we can use a case control study design, but the sampling into the design can either be consecutive or non-consecutive, right? If I go to one factory and take all those who don't have outcome B and all those who have outcome B, then that is a consecutive design. Everybody has been accounted for. They either have or don't have outcome B. But on the other hand, if I allow them to volunteer, so we have a group which has got outcome B and a group which doesn't have outcome B and a group which didn't volunteer to come into our study, so we don't know the outcome. So that would be an example of a non-consecutive sample. Or if I go to the milk factory and take those with the disease and go to the sugar factory and take those with the controls, that would be an example of a non-probability sampling which is non-consecutive, right? Another example is a cross-sectional study design can be used for exposure outcome study type or an epidemiological study type, right? So in the exposure outcome study type, you can use it to study causality, and in the epidemiological study type, you can use it to study association. Please don't worry about this. If it sounds confusing, we'll be repeating this over and over again. And I'm not claiming that my way of classification is the correct one. I think there are just so many different ways of classifying it. So it's just a matter of how we have been taught in the past, right? So I'm just breaking it up into its constituent parts. Okay, coming to internal validity sampling method now. There are basically two kinds of sampling methods. One is the random sample and one is the non-random sample. So let's look at the random sample. Now, population measurements, we call them parameters, and sample measurement, we call them statistics. Okay. Now, if you do, this is 1,000 of my master's trainees. If I randomly sample them and put them into a sample data set, I will be able to do both descriptive statistics like mean and standard deviation, as well as inferential statistics like 95% confidence intervals and p-values. What I'm trying to say is the results from my sample will be generalizable to the entire population of trainees because I randomly sample them. Now, coming to non-random samples, right? Let's say I've got 1,000 clinical master's trainees here, and I go to the library and take whoever is sitting down there. Now, this is a non-random sample. This small bit here is not representative of the entire population, right? So, the results from this sample cannot be generalized back to the main population. I can only do a mean and standard deviation of my sample. I cannot do a p-value or a 95% confidence interval. Now, most medical studies are of this type. Next, we come to the research methods proper. Again, sticking with the exposure outcome type of study. In the research methods, at least the following have to be mentioned. Okay, this is the PICO matrix that you will find in Cochrane collaboration reviews. Now, who is the population that you are talking about? What is the disease condition, the age group, the geographic area maybe? Then what is the intervention? Is it a drug or a device or whatever? Is there a control group? Okay, what is the outcome specified? Bleeding, death. Then we come to the methods proper. So first we have to decide, are controls needed, right? Second, if the controls are needed, we have to create two equal groups. Now, we create two equal groups by randomly assigning a large population of patients to two groups. Okay. Now, then we have to prevent bias before they enter into the study, and that we do by allocation concealment. Then we have to prevent bias after they enter the study, and that is done by blinding. So when you look at a study, you will look for all these main points. Now, another part of internal validity is data management. This is a big topic by itself, but generally it concerns itself with the issue of, is this data accurate and valid? Okay. For example, if you want to weigh something, the best way of weighing it is to go to France, which houses the prototype kilogram, right? So you go there and you measure it against that prototype kilogram. That is the most accurate. However, if you want to weigh a baby to calculate IV regimes, then you must use a hospital scale. If you use a bathroom scale, that is not accurate. But if you just want, if you are a manufacturer and you want to sew clothes for a baby, then the bathroom scale will be fine. I mean, maybe baby gets to wear some loose clothes, but no harm comes out of it. The next thing is, how have the researchers handled or minimized missing data? Okay, the best study can become useless if there is too much missing data or it has been improperly handled. A note on statistical analysis. We are still on internal validity here. Now, there are two kinds of statistics. One is the descriptive statistics and one is the inferential statistics. Now, inferential statistics is that p-value and 95% confidence interval that we see in almost every paper, right? Unfortunately, this is only interpretable under certain strict conditions. Firstly, there should have been random sampling, and the sampling is repeated. For example, there is daily sampling of all the cheese blocks in a cheese factory, right? So inferential statistics is only rarely applicable in medicine because we don't do random sampling for medicine, very rare. And we don't do repeated sampling of the same population, right? So this is something that was used in fields like agriculture, brewery, production line. It is more of an industrial method, but somehow it ended up being used in medicine. And now statisticians worldwide are trying to push back on this, right? The other issue is, it's not a question of whether we use simple or complicated statistics, but appropriate statistics. Now, we can do simple statistics like mean and median, but they may have no clinically useful meaning, right? So the statistics that we use has to be appropriate, and in our case, appropriate would mean clinically useful. Okay, a statement on the p-values. Now in 2016, the American Statistical Association came out with a statement on the p-values warning against its use, and apparently this organization seldom if ever issues any press statement and things like that, right? But they took a very strong view to researchers, especially doctors, using p-value. You can go and read up on that. Now, the next in internal validity is the results. Now, the results is what you see is what you see. That's it, full stop, right? However, if it looks very outlandish, then you may want to look at other similar papers, or you may want to relook at the methodology. Now, a very, very important component of internal validity is study limitation. So, once you decide on your research question, what you need to do is you need to go to sleep and dream of the perfect study. The perfect study is sometimes known as the counterfactual study. That is the study with no study limitations, and it will give you the true results. That means it will tell you that the weight of the babies the average weight of the babies is 3 kilograms. However, unfortunately, this true value is unknown and will most probably forever remain unknown to us. Then when you get up the next morning and go to work, you will realize that you don't have enough time, you don't have enough money, you don't have enough patience. So as a good doctor, you will just ensure that you do a fit for purpose study. Now, usually fit for purpose studies will hopefully give you an answer very close to the true results, right? The good thing about the fit for purpose study is the answer is known to us. So study limitation is all those factors that will bias your study results away from the true results. Or another way of putting it is, study limitation is the unknown value of the counterfactual study minus the pragmatic study, which the value is known, right? So in reality, we never know how far from the truth we are, but we know how imperfect our study is, right? And how far it deviates from a perfect study. So we use that knowledge to try and decide whether our results can be used or not, or whether our results are well fit for purpose. Now when we talk about study limitations, we have to talk about it in terms of study design, data management, and statistical analysis. Now, when it comes to the conclusion, the study conclusion is actually the study results moderated by study limitations. So the conclusion, the average weight of babies was 2.8 kilograms. However, since we used hospital scales instead of the precise prototype kg in France, there might be some error. But it's unlikely to be of clinical importance. So you can see that the conclusion comes in at least 3 parts. One, it states the results. It tells you the limitations that are built into that result, and it gives you the researcher's opinion whether or not it's likely to be of clinical importance. Now, you can't disagree with the researcher's results. As I said, it is what it is. But you can disagree with their conclusions, because you can say, yeah, but that small error might be clinically important if it's like a preterm baby or something like that. So, as I said, the results we can't really argue with, but the conclusions we sometimes can. Now, coming to the infernal problem of sample size. Now, sample size and inferential statistics are closely related to the way that we obtain our study sample, right? There are two main kinds of sampling. One is the random or probability sampling, and the other is the non-random or non-probability sampling. Now, random sampling, you have got the simple, stratified, cluster, etc. The non-random, you have got consecutive, non-consecutive, and different types like quota sampling and things like that. Now, sample size calculations are only available for random samples. For non-random sampling, there is no sample size calculation available. Unfortunately, random sampling is quite rare type of design in medicine, whereas non-random sampling is more common in medicine. Right? Now, this was a book written for WHO in I think 1991 by some very top-notch statisticians. Now, if you go to page 52 of the book, you will find this is the book on adequacy of sample size in health studies. Okay, it tells you how to calculate sample size. Now, let me read the relevant passage to you. In probability sampling, because every element has a known chance of being selected, the reliability of the resulting population estimates can be evaluated objectively through probability theory. Consequently, individuals using the survey estimates have some insight into the reliability of the estimates. In non-probability sampling, no such insight can be obtained mathematically. Only probability samples will be discussed in this manual, right? So, this manual, which is supposed to help us calculate sample size, only deals with probability sampling, and most medical studies are not probability sampling. So, think about that. Again, coming back to the issue of external validity, it is not the business of the original researcher, right? You have to decide as a reader whether the study can be used for your patient. Now, sometimes people confuse the question of statistical validity versus non-statistical validity with internal validity, external validity. Okay, don't worry about it if you don't understand it now. We'll be repeating all this later. When you don't have a defined population and there's no random sampling, example, a randomized control trial done in Beijing, is it applicable to all of China? A randomized control trial done in China, is it applicable to Malaysians? So these are external validity type of questions. Now, statistical validity is a function of internal validity, whereby I go to Seafield Primary School with 1,000 students, I randomly sample and get a sample of 100 students, I average out their height measurements. Now, the results are applicable back to the 1,000 other students, okay, with the caveats such as p-value and 95% confidence intervals. Okay, we have come to the end of this presentation. Terima kasih and thank you.